Good morning, everybody. I'm Peter Donaldson, and I'm president of the Population Council, and on behalf of the Population Council, I'm delighted to welcome you to this panel discussion on turning the tide for girls and young women, how to achieve an AIDS-free future. And I thank you for coming, devoting your morning to this. Population Council researchers around the world are studying important population health and development issues. We're working hard to stop the spread of HIV, to provide women with more reproductive choices, and to ensure that young people lead full and productive lives. We think the evidence shows clearly that our research has led to better policies, programs, and improved technology. Our research and that of lots of others shows that if we improve girls' health and keep them safe and in school and give them critical information and a say in their own lives, we can reduce their risks of HIV and increase the likelihood they'll be on the path to full and productive, healthy adult lives. Today we're releasing a report on the outcome of 3 PEPFAR-funded projects that the Council conducted in Ethiopia. The report is called Building Assets to Thrive, and it's on your chairs, and I encourage you to read it. You all have a copy at your seat, and I think you'll find it an important and easy to digest report. I want to thank PEPFAR, USAID, the UN Foundation, and our other donors for their support of this work. And I also want to thank our partners in Ethiopia, particularly the Ministry of Women, Children, and Youth Affairs, and their regional bureaus and the NGOs we work with. Without our partners' support, this work would have been impossible. I think one of the important takeaway messages is that the projects that you're going to hear about this morning demonstrate that well-designed interventions that are based on thorough formative research that are designed from the start to be replicable and scalable, and that are monitored and adapted throughout, can really reach a large number of the most marginalized girls and successfully address the vulnerabilities that increase their HIV risk. So you can make a difference. We can make a difference. We're eager to share our experience and analysis from Ethiopia this morning, but we're equally eager to hear of your experience, to hear the lessons that other institutions and other researchers have learned. We're eager to learn from you. And so, therefore, we're very pleased that we're able to bring together both this distinguished audience and this wonderful panel that we have of discussants today. The plan is to first hear about the government, about PEPFAR's perspective on reaching girls and young women to achieve an AIDS-free future, and then to hear more about our experience in Ethiopia, including the strategies that we implemented to find the most vulnerable girls, which we think is an important message from this research. I'd like to begin by introducing our keynote speaker, Dr. Daniela Ligerio. Dr. Ligerio serves as Special Advisor on Gender at the Office of the U.S. Global AIDS Coordinator at the Department of State. She is the person who makes sure that gender issues are fully integrated into PEPFAR-funded programs for prevention, treatment, and care. Dr. Ligerio earned her PhD in counseling and community psychology at the University of Gender, and she focused there on gender issues, HIV, and public health. And she's worked in a number of positions as a health and gender specialist, now at the State Department, but previously at the World Bank and the U.S. Senate, and at UNICEF. She's also worked as a clinician, counseling the survivors of gender-based violence. And after Dr. Ligerio's presentation, we'll pause for some questions. We'll have opportunity for a small number of questions, and then we'll move to the panel discussions, and then we'll have more opportunity for questions and comments after that. But Dr. Ligerio.
Thank you. Good morning, everyone. Thank you for that introduction. Thank you also to the Population Council for all the excellent work you do. This is a great report. I was able to look at it before today. Thank you to the Kaiser Foundation for hosting us, and to the government of Ethiopia, who's here represented, and all the great work that you've done there. Was said before, I'm Daniela Ligerio, and sometimes, it's funny, you got my name right, which is great, because yesterday I was on a panel and I was introduced as Daniela Lingerie because of auto spell. That was kind of funny. So. Jero is better. So what I'm going to do today is talk a little bit about PEPFAR's perspective on preventing HIV among adolescent girls and young women. And I'm really honored to say that Ambassador Deborah Birx, who started her tenure as Global AIDS Coordinator about 4 months ago, has really made this a priority for her time here, and it has us all working very hard. I see people in the audience who have been working very hard with me and others to really think critically about how can we do a better job at preventing incidence in this population. And so today I'm going to talk a little bit about where we are in terms of the data and what we know, and then think a little bit about what are those next steps and the way forward. So that's pretty much how I'm going to structure my presentation today. Let's see if this works. I'm not sure where to point it. Maybe not. There we go. That's me. Okay, so this is the first slide I want to show, and the reason I want to show this is because it's really important for us to remember that overall, we have had an impact. We have been able to reduce infections, and you can see here per region what's happened. I mean, we were on this upward trend that was extremely scary, and over time have been able to bring down incidence in pretty much every context. However, you know, the challenge has been with certain populations, and we'll say a little bit more about how this challenge persists in young women and adolescent girls. But I think it's important to remember this in the broader context of success. And in fact, we've seen a lot of success in certain areas related to women and girls, like, for example, ART. If you stopped and went back 15 years and said that we were going to have close to 4.5 million women and girls on ART in the developing world, it would have been unthinkable. And people would have said, there is no way you can do that. And you'll remember all the conversations about we can't do ART in the developing world, and it's not going to work. And I like to look at this slide and remind myself that, you know, if we come together as a community and really decide we're going to do this, we can make it happen. And so the same is true for prevention with women and girls. But we need to come together, and we need to make it a priority. So this is good to remind us ourselves of what's possible. But there is a lot of unfinished business in this area, and I want to show you a couple of data points here. The first is to look not only at incidence and prevalence, but also size of the population. A lot of times I go places and people present incidence and prevalence data that's extremely high for certain groups. But then if you think about what is the size of that population vis-a-vis the overall population in the country, it's not necessarily that large. And so this graph really helps us see that in Southern Africa, particularly in Southern and Eastern Africa, young women and adolescent girls are by far the largest group at risk. And we have not really treated them as a key population in the way that we have other risk groups that we, you know, have labeled key populations. So this is important for us to think about. It's also important to know that this isn't true everywhere. So we need to really be focused on where this is an issue. This isn't about saying we're going to prevent HIV among women and girls everywhere we work. It's about really understanding where is this a challenge. You've seen all these data. I mean, and the recent UNAIDS Gap report highlights it year after year, and I'll talk a little bit more about that. We see this. But basically, what the situation in sub-Saharan Africa is that at a certain time during, you know, adolescents and young people's lives, the disparity between men and women becomes gaping. I mean, and then throughout the lifetime before and after, it equals out. But there is something happening in this group where all of a sudden we're going from low levels of incidence and prevalence, and there's this jump that's happening. And it varies by country, it varies by region, but if you look at it overall, something's going on there. And in fact, it's really important to also understand, like I said, numbers of new infections and really proportionally where the largest burden is. And so this graph shows you, this is new infections per week. And you can see in this population of 15 to 24-year-old young women and girls, you can see that South Africa, by far, is the place with the highest burden. But there are several other countries that might not necessarily have high incidence or prevalence, but because of the size of their population, are also contributing significantly to HIV overall in terms of numbers. So really, we're talking about a handful of countries where this is a challenge. And, you know, this is a graph from South Africa. We pretty much see a similar curve happening in most of the Southern and Eastern African countries. It might peak a little bit later, a little bit earlier, but pretty much we see this where, you know, when you're looking at before 14, you basically have children who were infected vertically, and then once they start becoming sexually active, you know, the women and the girls just spike. And that trend continues and persists throughout their lifetimes. This is a graph that Judith Bruce asked me to put in, and I'm so glad you did, Judith. You've been such a champion, to really show over time what has happened. And you can see that in some places, like in Ethiopia, which is the light blue line, the trend is shifting in terms of ratios, male to female to male HIV prevalence ratios. But then you look at other countries like Mozambique, South Africa, etc., and some things happen where we've stalled, and we've just stayed there. And so all of this really indicates to the fact that we need to start thinking differently and doing things differently, because what we're doing right now is not necessarily working. This is a busy slide. What I want you to pick up from this slide is that the light green, the green is adolescents age 15 to 19 who know their status, and the blue is 20 to 24. You can see on the right-hand side we have boys, and on the left-hand side we have girls, and you can see that we actually test more girls and women than we do boys. We do a better job. But I want you to focus on the difference between the 15 to 19 and the 20 to 24. We don't do a good job at testing the adolescents. We really pick them up more later in life, mostly through PMT-CT and ANC. So you have this situation where, you know, kids are born, you follow them through the first years of life, and you do testing, and then you pick up, you know, the women and the girls again once they're pregnant at ANC. But we're not doing a good job at testing in between and really understanding what's happening for that population. For many girls, first sexual intercourse is unwanted. That's clear. We know that. We've been doing, with CDC support, violence against children surveys in a variety of countries, and you can see anywhere from 44 to 23% of girls are saying that their first sexual experience was unwanted. So something to think about as well. And these are national level data for these countries. The other important thing to understand is that vulnerability, you know, there are factors that create vulnerability, but then there's also the interaction and the combination of these factors. So here you can see some data from South Africa, from Lucy Kluver and her folks, looking at how, you know, the difference between transactional sex between someone that lives in a healthy family, someone that has an AIDS sick parent or caregiver, that is abused and hungry, and then all those things together. You see that jump. So there's a compounding effect of vulnerability. So this really speaks to the fact we need to find the most vulnerable that are experiencing the largest amounts of different vulnerability factors. And then the final thing is that we know that HIV/AIDS is the leading cause of death, not only for young women and girls of reproductive age, but specifically for adolescents in sub-Saharan Africa and in Southern and Eastern Africa. And you can see that worldwide it's number 6. So really there's a difference here in terms of what's happening in mortality. So the way forward, and this is what I want to spend a little more time on. The bottom line for us, I think, as a community, and I'm excited because I feel like more and more people are starting to understand this, and the data are the same every year, and so it's like, okay, something's not working. We need to do things differently. We cannot continue with the same prevention programs we have now. They are not working for this population. And so we need to ask ourselves a few basic questions like who, where, what, and how. The who is the idea of vulnerability, and you'll hear more about this later, but these vulnerable girls and young women are out of school, they're married, they have a sick caregiver, they've experienced violence, they're hungry. So we need to find them. We need to understand who they are and find them. We shouldn't have a national strategy that's a blanket, strategy that applies to all girls and women equally. Again, I have this slide before, sorry. You saw that before. The other issue is the where. And this is something that Ambassador Birx has really stressed, this idea that even within a country with high incidence and prevalence, you have microepidemics. This gives you a sense in Tanzania, the difference between regions. And then if you go even further down to the district level, you could see differences. So it's important to really say who we're focusing on and then where we're focusing. So we don't necessarily have, these national strategies, again, that are intervening everywhere in the same way. And the what is really important. And what we need is a combination prevention approach of evidence-based interventions that is brought to scale and that ensures saturation. So in this region with high incidence, you need to find those vulnerable girls and young women and then saturate with interventions so that you have the same girls and women reached with various interventions instead of one intervention reaching this girl over here and one intervention over there. And that's different. We have not been doing this in a systematic, scaled-up way. I am not going to spend too much time on this, but basically, I want to tell you a little bit about an exercise that we have been undergoing within PEPFAR that includes folks from many agencies, and it's really looking at the evidence base. And we've basically tried to classify the evidence that exists for different kinds of interventions. And we could talk for hours about whether this makes sense or not and whether it's the right classification and what is evidence and what are the levels of evidence. But this is just to give you an idea that some interventions have more evidence than others. And some have shown, results in one direction, and some have shown mixed results. So this gives you a sense. When it's green, it's pretty much consistently showed effectiveness and largely showed a consistent effectiveness and has good evidence. And then the yellow is when that's happened, but the evidence is relatively low. And then the red are the things we don't want when they've shown to be harmful. There are things we've done that we know don't work and are actually harmful. And then the orange are the ones with mixed beneficial effects. So we know PrEP works. That's an A2 on biological outcomes. We know the issue is adherence there for women and girls. We know that ART for male partners has the ability to reduce incidence for girls. We know that VMMC for male partners does. We do know that for female and male condoms. We know that for PEP and post-rape care. We know that there's effects on behavioral outcomes for post-violence care beyond PEP, like trauma-focused counseling, as well as kind of case management and advocacy post-violence care beyond PEP. We know in terms of behavioral outcomes that, yes, parenting programs have been shown to be effective, as well as short-term emergency housing. We know that education subsidies and support like uniforms, fees, et cetera, have also shown some behavioral outcomes. We know unconditional cash transfers have effects both on biological and on behavioral outcomes. We also know that conditional cash transfers, for example, that are conditional on education, also have similar effects. We know that parenting, caregiver, mentor, skills building programs, you'll hear a little bit more about those kinds of programs, I think later today, have also shown positive effects on behavioral outcomes. We know that counseling and testing, even though we haven't necessarily shown an outcome on incidence per se, is prudent practice because it's the entry point for a lot of these other interventions. The same is true for adolescent-friendly services in terms of what we're doing with the behavioral outcomes. And then we also know that combination social economic approaches and thinking about contraceptive mix might be prudent practices as well. And this is more related to the dependence on injectables that we see in some countries in Southern Africa. So the idea here is to really think about a core package of interventions that has various pillars beyond the health sector, that looks at psychosocial, education, and economic. We also know that just like vulnerability is compounded, there are compounded effects of interventions. So this data shows that when you look at cash alone and then you look at cash plus care, the effects on risk behavior for HIV decrease significantly. So we also need to think about putting together these packages of interventions so that they will have a larger outcome. And that basically means a new paradigm for us in terms of HIV prevention that goes beyond the school sector. And here you have additional data looking at things like child-focused grants, free school, and school meals, all having an effect on incidence. And I'm wrapping up. I have one more slide. The how is also very important. And this, again, and we've been talking about this within our office around fast-tracking the epidemic. And this is what the ambassador is having us do for every PEPFAR country, period. Look at the epidemic, figure out who your vulnerable populations are, focus on a core set of evidence-based interventions that work for that population, align geographically so that you make sure you're saturating districts and specific regions with those interventions, and then saturate them, take them to scale in that region. And finally, in that process, make sure you are targeting the most vulnerable. In this case, we're talking about young women and girls. So this is the quote I like to end with, because all of you are making a difference. And even though it might feel like sometimes you're not, you are. And I think that together we can make much more of a difference. So thank you very much. I think I have a minute for maybe one or two questions. Do you want to do that?
Yeah, and somebody will bring a microphone to you, and you please tell us your name before you ask the question. Any questions?
Hi, thank you so much. I'm Suzanne Petroni with the International Center for Research on Women. I wonder if you can share any evidence that you might be aware of regarding the death rates from HIV and AIDS among adolescent girls. We know from WHO that we're making some progress in keeping children alive who are HIV positive, but then there's this drop-off and an increase in death rates among girls. Is there any evidence regarding why this is happening? Are they not being treated? Do they stop treatment? These may be perinatally infected adolescents. I haven't seen much evidence on that. So.
Okay. Should I take one more question and then answer more than one? Because I know we don't have a lot of time.
Hi, how are you? I'm Monica Pham. I'm Barbara Lee's senior advisor for AIDS. My boss is actually meeting with your boss on Friday, so
Great.
if you can answer this question regarding outreach to especially vulnerable girls, and the outreach that how do you find them and how do you get them in care?
Right. Okay. Should I answer those and then? Okay, so those are similar questions in a way, and it's really exciting because I think it was a month, God, it feels like forever. I think it was only a month ago, we launched a new initiative called ACT that's really looking at accelerating pediatric treatment. And that initiative was launched it was launched specifically to do pediatrics, but looking at 0 to 19. So very conscientiously, the adolescents were included in that. And right now, there's a meeting that's being prepared in 3 weeks where all the teams that are part of this initiative are coming together to present their plans. And what we've asked them to do, and they've never really done this, is for the 5 age bands that we now require PEPFAR indicators to disaggregate by, to specifically lay out plans for testing, for retention, for adherence, all of those pieces for those different age bands. And so the point being that we have some sense of what's happening with adolescents. It's everything from they don't adhere, we're not testing them in the first place, there are issues around accessing ART, and so all of those things together need to be thought through when you're targeting. But you can't have a strategy that does 0 to 19. You have to have a strategy that does 0 to 5, 6 to 10, 10 to 14, and then the 15 to 19, because those are different groups, and you're going to find them in different ways. And to your point, the finding of the adolescents is so important. One of the things, I see Gretchen is here and a few other folks from our OVC working group. One of the things we've been talking a lot about is how do we use those OVC platforms to find those vulnerable girls and adolescents in a way that, just doing the clinic-based testing and case finding is not going to work. And so we really need to be creative and think about our broader platforms and how we find those vulnerable girls and adolescents. Done? All right, great, thank you.
I'd now like to ask the panel members to come, and I'd like to introduce Dr. Jennifer Cates, and I think she'll make some opening remarks, and then we'll have the panel discussion. Dr. Cates is Vice President and Director of Global Health and HIV Policy here at the Kaiser Family Foundation, and we thank her and the foundation for allowing us to use this space for this meeting. Jennifer oversees the Foundation's policy analysis and research focused on the government's role in global health and on the global and domestic HIV epidemics. She publishes and presents widely on global health and HIV issues, and she's particularly well known for her work on analyzing the U.S. government investments and other government's investments in global health and mapping and the U.S. government's global health architecture, programs, and funding. And those of you that, I'm sure most people in this room use the Kaiser Family Foundation website, and it's a priceless source of information, and a lot of that comes from Jennifer and the work she supervises. Jennifer received a PhD in health policy from George Washington University, where she's on the faculty now. She also has a master's degree in public affairs from Princeton University and another master's degree in political science from the University of Massachusetts. So please, the floor is yours.
Thank you very much, Peter, and thanks to the POP Council for organizing this important session. We're really happy to be able to host. That's the fun part for us here at Kaiser, to pull people together to have important conversations. And I also, in addition to Peter, I just want to thank the whole team at the POP Council, particularly Gina, who really made this happen, this event, and pulling people from all different parts of the world really to be here. And I'm really honored to be able to talk about this topic, which is really important, not just to the work of the foundation, but to me personally, professionally, addressing the issue of girls and young women at risk for HIV, and how we do that, how we really get ahead of this. And I agree with Daniela that maybe there's some pivotal moment that we're at, or critical turning point, because there have been increased conversations about a topic that many of us have been trying to get more attention to for a long time. And I want to thank Daniela and Ambassador Birx and the PEPFAR team for really bringing new attention to this now. So to follow from what Daniela presented, and one of the things I'm really excited about, and when I heard about this opportunity to be part of this, is that if you look at the new report from the Population Council, one of the things it has that I think a lot of us have been wanting to see more of is concrete examples of how you actually reach young girls to make a difference in their lives. Because we have data showing the disproportionate impact. We have some data showing how to address that. And I really loved what Daniela put up with the table showing how the different types of interventions, their effectiveness. But we also want concrete examples. We want to understand, how do you put this in place in real communities with real young women, working with NGOs, working with governments. And that's exactly what this report is about. But it's focused on Ethiopia, but it's beyond Ethiopia, I think. So what I'm hoping we can do in this panel discussion is hear a little bit more about that report from the POP Council author, but also from our other experts on the panel about what their takeaways are, what we can all do to really get ahead of this. So I'm going to briefly say who we have on the panel. Their bios should be in your packet, and there's lots of incredible things that they've all done. So I'm just going to say who they are and where they're from. We first have Annabelle Arolkar, who is a senior associate and the country director of the POP Council's Ethiopia office and the lead author of the report that we'll hear about shortly. We also have Haile Lul, who is the director of Women and Youth Mobilization and Participation Enhancement at the Ethiopian Ministry of Women, Children, and Youth Affairs. So our guest who traveled far to be here. Judith Bruce from the POP Council, who's a senior associate and policy analyst there, and Wafa El-Sadr, who's a professor of epidemiology and medicine, the director of ICAP at Columbia University Mailman School of Public Health, and director of the Global Health Initiative at Columbia. So we have a great group to talk about these issues, and I'm going to turn it to Annabelle first, who will tell us some more about the report and what you learned and how we can use that as a springboard for today. Thank you.
Okay, thank you very much. So I'll take a few minutes to talk about the document that you've received, I think, on your chairs, which is entitled Building Assets to Thrive, Addressing the HIV-Related Vulnerabilities of Girls in Ethiopia. And as you can see in this document, it profiles the development and design of 3 HIV prevention programs designed to support the poorest girls in the poorest areas of Ethiopia. The design of these programs is firmly rooted or anchored in evidence, so it's not based on anecdote or it's not based on what was popular at the time, and at the time it was about 10 years ago that we designed these programs. It's based on qualitative and quantitative formative research that's intimately tied with the design and the implementation of the program. And as well, we have low-tech qualitative studies that were woven throughout the process to guide adjustments and program developments. So as I say, when we came to this work at the very outset, we consciously wanted to systematically identify the poorest adolescent girls at the highest risk of a negative outcome. And what we did at that time is we wanted to identify indicators to indicate to us what would be the adolescents who we thought were not on track, or what are the adolescents who are in conditions that you wouldn't commonly think of adolescents being in. So we thought of 3 different indicators at that time. That was not being in formal schooling, and this is particularly for adolescents below the age of 15, living away from parents, and again with a special focus on the younger adolescents, and then social isolation. So when we think of young people and youth and adolescents, we think about them having peers and friendship networks. But we were looking specifically at the young people that didn't have that were socially isolated and reported few or no friends or very little social support in their communities. So we did survey research in slum areas of Addis Ababa as well as in the Amhara region. And the Amhara region is the 2nd largest region in Ethiopia with the highest rate of child marriage. And once we did those surveys, we asked ourselves the question, so which categories of young people in these poor areas possess those characteristics? What do they look like, those who are out of school, socially isolated, and living away with friends? And if you took that survey data and analyzed it, overall, girls were far more likely to be in those conditions of out of school, socially isolated, and living away from parents. And then further analysis, 3 main groups sort of emerged from this data. This was married adolescent girls in rural areas, and in urban areas, child domestic workers and other categories of rural-urban migrants. And I think in identifying those 3 groups, I think we were pretty much on track there, because when we do further analysis, for example, of urban domestic workers, child domestic workers, you see that they're in really horrific situations. I mean, the girls in the Mercado area, little girls working in domestic work, they reported in our survey at that time working an average of 64 hours per week by their own estimate, and they earned on average only the equivalent of $6 per month. And compared to other categories of girls, they were more likely to report early first sex as well as forced first sex. So we designed these 3 programs based on the research that appear in this publication. Baru Tesfa is Amharic for Bright Future, and it was the program for urban girls living in mainly slum areas and mainly attracting child domestic workers and rural urban migrants. Meseret Hiwat means Base for Life, and it's the married girls program that was implemented in rural areas of Amhara region. And then Addis Burhan, subsequently Addis Burhan, came out of the work of Meseret Hiwat, which was the program for husbands to help them be better supporters of their wives, including these child brides. And the design of these programs is relatively consistent across these target groups. They were explicitly designed to address these indicators. So, for example, when you think about social isolation, in order to address that, we mobilized girls groups to give girls the chance to build their friendship networks and spend time with other girls who are in similar situations as they are. And then we attempted to address girls living away from their parents. So in order to do that, all of these girls groups were led by adult female mentors. Now, this was 10 years ago, or roughly 10 years ago, and that was when the peer education approach was very, very popular. But we felt that these girls really lacked a caring adult in their life, someone who would advocate on their behalf in case of a problem, someone who they could go to in case of a problem. So we felt that mentors could, in those communities, serve as kind of an advocate or a pseudo-social worker. And then as well, all of these groups included some amount of non-formal education to address the deficit in education. And through these programs, we've reached a very large number of girls. This is over 60,000 in the urban program, Baru Tesfa, and about 250,000 married girls through Meseret Hiwat, over 250,000 married girls. Despite a lot of initial skepticism that we could do that. We learned a lot during this period, during these past years of developing and implementing these programs. One of the things I think we learned was don't be afraid to do the hard things. When we started this work and when we said we were going to work with these groups, a lot of people were very skeptical and said it can never be done. We'll never be able to do it. Married girls will never be allowed out of, by their husbands or in-laws, and similarly, the same for domestic workers. But I think we proved them wrong, and if you see the scale and the differences made in these girls' lives and the demand for these programs, I believe we proved the skeptics wrong. The second thing I just wanted to highlight is we learned about the importance of the ongoing and meaningful engagement with data and research in the course of program design and implementation. We didn't look at this research as as a donor requirement or something that we ticked off on our work plan. It was intimately involved in the entire process. And even after we designed the program based on this formative research, we still didn't think we had all the answers. We have always approached this as we always have a lot more to learn about the lives of these girls. So we used rigorous research to continuously try and understand what's going on in their world and how we can make that world better. So I'm very proud of the difference that this has made in the lives of a lot of the poorest girls in Ethiopia. I guess I am going to end with a kind of a plea or a request, and that is that right now there's a lot of momentum and a lot of interest in investing in adolescent girls. From my vantage point at the meetings I go to in Ethiopia and the workshops and also elsewhere, a lot of people think the best way to do that is to invest in the people around the adolescent girls. So we often talk about parents, husbands, religious leaders. That's true, and that's very important work to do. But I do think that our priority for the next generation of investment is really focusing the bulk of these resources at the girls and building their assets to give them a better chance at a better future. Thank you very much.
Thank you. Thanks, Annabelle. So now we're going to go down the line here and hear a little bit from each of our experts. Then we'll get into questions. So next we have Haile Luz-Sayum from the Ministry of Health of Ethiopia, who will tell us a little bit about the government's role in addressing this.
Thank you very much. First, I would like to express my appreciation for Population Council for investing in adolescent girls in Ethiopia and also for giving us this opportunity to be part of this event. Investing in most disadvantaged adolescent girls is beneficial not only the girls themselves, but also the communities they live in. At this forum, I would like to call to renew our commitments, to honor our commitments to support adolescent girls because they are the ones who sustain transformation and change in Africa. The Ethiopian policy, normative and strategic frameworks are founded on the constitutional vision, which aspires for the creation of one political and economic community capable of ensuring lasting peace, democracy, and socio-economic development in the country. Based on this constitutional vision, our government has devised three most important directions, which these directions are: one, ensuring broad-based, accelerating, and sustained development. The second is guaranteeing participatory democracy. And the third direction is to ensure equitable development, beneficial for the people. Development is not alone enough. Development should be equitable, beneficial to the people. Based on these strategies, we have different strategies, we have different enablers in the country, especially for adolescent girls and young people in general. The most three important enablers in our country are: one, the political commitment, the political will, which is expressed in terms of having different policies, strategies, and normative frameworks. For instance, if you take the women policy, if you take the young youth policy, if you take adolescent strategy for development and participation, which is based on inclusion, representation, and participation of adolescent girls. If you take our educational policy and others also. For instance, if you take the 2013 strategy on harmful traditional practices, it is also focused on adolescent girls and women to eliminate all forms of harmful traditional practices, including child marriage and other violent acts. We have also the recently commitment of the government to eliminate all forms of harmful traditional practices and violent acts within the next 10 minutes. This commitment is renewed at the Girl Summit in London last July. We have also the HIV/AIDS policy and strategy, in which we are envisioning to create an HIV/AIDS-free Ethiopia within the next 10 years. Therefore, all these policies ensure the commitment of the government. The other enabler or strategic direction is that public ownership and community participation. In this regard, we have different supportive, innovative mechanisms at the grassroots level. For instance, if you take the health extension system we have, which is populated by young people, female, over 40,000 extension workers at grassroots level. We have also the Women Development Army, a new innovation, which consists of around over 450,000 groups with a membership of 11.3 million women at the grassroots level. We have also the Community Care Coalition, which is also a system that address all community problem, local problem within the locally available resources and structures. We have also the social, community-based social development workers. We have the agricultural development agents and so on. All these structures are at grassroots level, at community level, to create public ownership and community participation. The third strategy is a strategic partnership with different non-state actors, so that the government cannot alone address all problems, not only in the areas of HIV/AIDS, but also other vulnerabilities, which we call in our country socio-natural vulnerabilities of any kind. Therefore, based on these strategic directions and enablers, we have achieved much in the reduction of harmful traditional practices, in bringing more adolescent girls into school. If you take currently, we have over 11 million young people in the schools, including over 10 million adolescent girls and women and young women. Therefore, based on these achievements and results and practices, still we believe there are things should be done in the future. One is we have to invest, we have to enrich more adolescent girls with school, health, livelihood development, economic empowerment, and safe space amenities. The second is capacity building for the government itself, because we have structures from the federal to the local level, but government structures have capacity limitations in terms of implementing different programs, in terms of enforcing the law. Capacity building for Girls Forum, capacity building for women development armies. And the third one is scaling up. Scaling up the different programs, the different projects which are with best practices and experiences. Finally, I would like to thank Population Council and also call every interested non-state actor to work in the country in addressing adolescent girls and women. Thank you very much.
Thank you. We'll move right on to Judith.
Thank you. Well, the previous speakers have given us both inspiration and a map. I'm going to talk a little bit using Ethiopia as certainly an inspiration about some of the general principles that Daniela highlighted at the end of her talk. I really think, basically, looking at those graphs, we now have to be at the inflection point to turn this downwards. So it's basically, if not now, when? We've been looking at this for 10, 12 years, and if not us, who? But I think we have a lot to offer. The things that I think will propel us forward from here are creative use of the data we have, and we have a lot more data now, a granular approach which was suggested, so going to the subnational districts, we have high concentrations of girls, and we've had a lot more indicators. We had, girls, the proportion of girls 10 to 14 living apart from parents and not in school. And by the way, just recently an exercise in Sierra Leone, some of the most effective areas have more than 35% of the girls 10 to 14 living apart from parents and not in school. We have more refined data on sexual coercion. We have drilled down and mapped data that shows what proportion of girls hold a negative social norm with regarding the expectation of violence. We have data on violence, et cetera. These can be layered. And maps are marvelous because everybody's in them. And we had the experience early on in this experience of showing maps to the Ethiopian parliament with these conditions laid out, including child marriage, but there were others. And the response was, it's like a math manipulator. Everybody's in it. So I think data and social cartography are friends, but now drilling down to very granular levels, because the theory of change, I think, has to be local change, increasingly, that you find the places within those subnational districts where you have the highest concentrations of those, they're usually girls, at the highest risk of the worst human rights abuses at the youngest ages. Within that sort of theory of change, there's other data to look at, which is local capacity. And Dr. Haile has mentioned, they're fielding armies of women now. That's good. In Bangladesh, there was a huge change in the family planning effort when 11,000 female family planning workers were fielded. And then they were actually given a mission that they could craft a local structure and create a delivery system. And Daniela also highlighted delivery systems. Among the many brilliances of the programs that Annabelle described is that we need to create local delivery systems. We can attach them to structures that are already there, and we have to have their support and approval. But these platforms, perhaps the OVC platforms, can be used. We have a new tool called the Girl Roster, which I have to plug. But basically a simple way of just finding out who's in the walking community, because for girls, and for a lot of people, if you can't walk to it, you can't get to it. But the capacity to deliver, and what to deliver. What if we get an HIV vaccine? Where are we going to deliver it through? So the investment in those platforms and in those local cadres, because the cavalry really is there. Again, using the data, in most places, some high proportion of girls have graduated from high school, but they've been left on the shelf. That's our army. And slightly older females with some skill, or the females in the mentors in Beirut, so a high proportion had lived through some of the same hell these girls have. And these are but they need to be invested in. the girls and those that guide them. And then being really clear on our theory of change. Luckily for us, right now, everything we do in the short game, it also feeds the long game. There's nothing that we're talking about doing with these girls, building their protective health, social, and economic assets, which isn't codified in all the ways that Dr. Hailey just mentioned, honored, but it plays into the issues of intergenerational poverty and health. It is the antidote. In the case of Ethiopia, and we have data for 15 countries now, but let me give you some rates to keep in mind. Beginning with Ethiopia at about 50%, and rising to Liberia with 42%. The proportion of girls, current adolescent girls who are currently adolescents who will be single mothers, either because they have a child before marriage or marital dissolution, which people don't talk about that much, is from 50% to 92% in Liberia. These girls are carrying the future of the workforce of the country. So failure to invest in them is planned poverty, and HIV is part of this. We have the tools to find the girls to make these investments, and among the beneficiaries in it, of course, will be the containment of the HIV epidemic.
Thanks. And Wafa, we'd love to hear from you. And you're not last but not least is Wafa, but we'll come back to everybody on this panel.
Well, thank you very much. It's a great pleasure to be here, and especially to follow all the speakers this morning. I had the great pleasure 2 years ago now almost to actually visit Ethiopia and to visit one of the sites of the program in Addis Ababa, and it was quite a memorable experience. And to see this program in action and to see these young girls and young women in a safe space getting a lot of the tools that they need to lead successful and safe lives was absolutely amazing. It was really magical. And some of the photographs in this report actually are fantastic, but they don't give justice to the magic that was in that room. You could almost palpably feel the lives of these young women being transformed through the program. So I'm a witness to the real thing. I think in many ways, I always admire the Population Council and its work for one very important reason, which is the commitment to generating the evidence and then taking the evidence to action. I think what we need is solid evidence, and not only the evidence, but also we need the blueprint and how to take this evidence into action. And I think that's really a fundamental part of addressing the needs and the urgencies that you talked about, Daniela, this morning. And what are the kinds of interventions that are needed? We talked a lot about the need for multi-component interventions, biomedical, behavioral, psychosocial, structural interventions. Those are really very, very important, and we need to be very thoughtful about how we're going to package these interventions in a way that will enable us to get the results that we are looking for. And then the other dimension is, what are we going to measure? And that's very, very important. It's an area that I think requires a lot of careful thought as to what are the outcomes of interest. And I think this report that we're launching and celebrating today gives us also a blueprint in terms of the dimensions of the various dimensions that we need to measure as we're trying to address something as complex as the lives of these young women, and to try to protect them from HIV and from other health threats. So I always think to myself that when you're thinking of any intervention, I call it the 5 S's. I'm into those things that I can remember. So number one, they have to be sound, which is evidence-based, very, very important. I think interventions have to be simple. Very complex interventions don't have a chance of actually being scalable. So sound, I think they have to be simple. I also think that they have to be also successful. Obviously, on the ground is very important. Then they have to be scalable. And you called it coverage, you called it reaching scale. That's very, very important. As our interventions need to be scalable, and we need to measure and understand how to scale an intervention or a package of interventions. And lastly, they have to be sustainable. They have to be able to be maintained, hopefully by the people on the ground themselves, with some support, but we want them to be there for the long term. So many of the components of the program the programs that we're actually talking about today, I'm fascinated by how it was designed, the participatory nature of the design of the program itself and the interventions. very smart design that included opportunities for adjustment, which I think is really important, is as we're delivering interventions, delivering packages, we need to be open to adjusting them, getting feedback from the constituents themselves or the stakeholders or the funders or whoever has a good idea, so that we can actually shape and reshape and refine our interventions as we move along. And I also got the sense that there was also a very big component of listening to what the community was telling the researchers, what the community was telling the people who were leading the program as to what their needs are. And that listening is very important, because that was a big part of also shaping the program itself, and hopefully even shaping the measurements that were ultimately determined to be collected on the program. So I'm excited about the potential for trying to take to scale programs like the programs we talked about today. They have tremendous potential. They need to be adapted, obviously, for different communities and different countries and different settings. But I think they offer us a blueprint into what we need to do as we move forward and as we're designing other packages, other interventions, other strategies and packages that hopefully will address the HIV epidemic, but also, even more importantly as well, address the livelihood and the future of these young women. And finally, I want to end by saying, building on something that Annabelle said, is never listen to naysayers. That's a very important principle in life. People will always tell you it can't be done, it's too difficult, people won't do it. It's not true. If there's commitment and there's determination and there are partnerships and the right foundations, I think amazing things can be done. So congratulations.
Okay, well, thank you to all of our panelists for providing us some food for thought as we get started. I have a couple of questions that I'm going to ask them, but then we're going to get to your questions. So start thinking of what those are. What we'll do when we get there is take 3 at a time and go back to our panel. So a couple questions, though, to start. I want to start with Annabelle. Again, I encourage everyone to read the report. There are a lot of gems in this report, and one that I would love to hear more about, that I think you, in the work that you did in Ethiopia, and then in talking about it, went to great lengths to help policymakers and program implementers understand what we mean about protective assets for girls. What are protective assets? Why is it important to understand them? And then how do you go about incorporating that into your program design and effort?
I guess I would go back to, the indicators that we were interested in, the very basic indicators that we were interested in, being lack of social isolation, lack of education, and lack of parental presence. And so, as I said, the programs were specifically designed around those elements. And I'm not sure I got exactly what you want me to talk about a bit more.
Well, I'm going to highlight it, that I thought this in the report, which is a great visual of what we mean when we talk about assets for girls. And I think one of the challenges that often happens in a policy discussion and a high-level program discussion is people don't get down to this level of explaining what we mean and how you can use this information to make a difference. So I just wanted to hear more about how you were able to incorporate that and see the results that you did.
Yeah, I think, as I say, these asset-building strategies were incorporated into the design of the programs. I think that with our partners and with other organizations or people in the field in Ethiopia, we did less explaining than demonstration. And I think that one can sort of explain theoretically why something is important and why a strategy is important. But I think that what actually convinced a lot of people was actually demonstrating that it can be done, and having people come and see the program and see, the difference it makes in the lives of these girls. Oftentimes when girls join the program, you'll see they're physically different. They'll be looking down like this. They're not engaged. They're not they have absolutely no confidence in themselves. If you go back to that same group after 3 months, the whole physical appearance and energy in the room is completely different. So I think that for us at the field level, it was a lot more of demonstrating that it can be done, and the visits by people that really made the big difference.
One quick follow-up. The other thing that you talked about earlier and came out in the report was how receptive the girls were to the interventions. Can you just say a little bit more about that? Because I think that's a really critical piece, that there's a desire to be part of this change.
Yeah, I mean, we designed the program specifically for the girls that were underserved. So we knew from the data they were not being reached by other programs. In that first survey, we had questions such as, have you ever had contact with a peer educator? Have you ever been to a youth center? We talked about the typical, do you listen to radio? These girls had very, very little exposure to any of the typical things that we'll try and design for young people, so that we knew we had an audience that was, hungry and eager to participate in these programs. And then we designed recruitment strategies to allow them to participate, because some of the main barriers for a program like Baru Tesfa was their employers. And so these mentors were women leaders from the community that would actually pay house-to-house visits and, talk to employers about the program. And if the employers didn't agree on the first visit, they'd go back on a second visit and a third visit. And so, that's why, we don't equate these mentors as teachers, but more of social workers. So the recruitment strategy was specifically designed to be able to reach into these households where these girls were, locked away in domestic work, and really draw them into the program.
Thanks. I'm going to go to Judith next, and I wanted you to talk about, and one of the things that we've been hearing and talking about in HIV for several years is key populations. Most are risk populations, now key populations. And more recently, young girls have been identified by some as a key population. Do you agree, is that a designation you would agree with? And can you talk a little bit about that and what we might take away from that?
I want to sort of begin with two things. One is just to build on what Annabelle said about this, to clarify the full theory of change. One of the really revolutionary things in Beirut, and I credit Annabelle and her team, they got information directly from girls, because girls were the first clients, and that's all the way through. So you ask the girl in the place where the girl lives, the parents have learned to say, we don't move a girl until she's ready, quote unquote. We might engage her. You ask the girl, as soon as she's engaged, 75%, Annabelle, you'll correct me if I'm wrong, were moved on some basis to someone else's homes, and 69% were sexually initiated before their menses. Now, this information will not come out in the community dialogue, and girls are the first client. They're the first and most reliable informats. The questions that were asked gave a great clue to the assets they needed. So I'm just in the Annabelle and Partners fan club here. Questions like, do you feel as intelligent as most people? That's a really good question, because that's a needle that moves pretty fast. Do you have a safe place to go in case of emergency? That's a good question, because the qualitative information shows that half an hour after you don't get your pay, your $7 a month if I recall correctly, you're on the street and there's about 10 minutes before this guy appears, right? So these become baseline questions. So, at the beginning, I don't feel as intelligent as most people. A few months later, I do. Some of it's by osmosis, some of it's by direct physical acquisition. Specific safety plans. I don't mean the general stuff. A lot of the content now in programs is far too general. You don't say to your child, be safe. You say, see that corner? It's really dangerous. The specificity of the information, the seasons of risk. Kelly Hallman, our colleague, in looking at risk assessment would say, the girls said, look, I'm most likely to exchange sex for gifts or money around November. Why? Because school fees are due in December. So to the question of key populations, you get to the area, and now you're in the place. And now the girls who have, the uncommonly socially isolated, living with one or no parent, out of school or not at grade for age, which we need to pay more attention to, and certainly those who are at that moment where they're supposed to transit to a secondary school. And unfortunately for females, that happens in the middle of their puberty. For males, that transition, they have their puberty afterwards. So girls move into new schooling systems typically where they'll be the youngest in the school exactly at the most vulnerable moment. So there's a more refined picture. So once you get to the places where you have high concentrations of girls who are married as children, especially where these are the under 15 benchmark, I know that the legal is 18, that's terrific, but in terms of investment strategies and this present conversation, I would especially look at the 113 subnational places in the world across 27 countries where 15% or more of girls are married under age 15. And it rises to 58%. But we can refine the data down. There are things also to look at, like not only the conditions of first sexual initiation, if you want to call that, but constructively, in many cases, it's rape. The girl is very underage, and the partner is more than 10 years older. Again, Sierra Leone figure, 85% of the girls are sexually initiated underage, and they're, say, commonly like at age 12. And 85% of those partners are 10 years or older. So all of these data can be compiled to get a picture of girls who really, if they ever had control, don't have any control. They're 12, they have a body. Who's going to use it? Is it me or is it somebody else? So unless there's a plan, and the ecological approach to that point helps, you can't really make progress as an individual. You need a team, and you need a delivery system, and that's what Beirut did. It's a real, having a really clear theory of change, and then drilling down to that more granular level.
Thanks. Wafa, I want to move to you next. One of the issues that we know from the data and from talking to girls and women that's important is integration of services. So meeting women and young girls with the services they need from prevention, care, treatment, family planning, HIV. Can you talk a little bit about that and what we've learned and what still needs to happen in that regard?
Yeah, that's very important. And I think every study where young women or women have been asked what would they like, what are their preferences, they've always highlighted as number one the integration of services, having multiple services together rather than having to go to different services. I think there's some innovations that are ongoing, but there's a lot more that needs to be done. I think most of the focus has now been around integration of family planning services and HIV-related services with some success. I think, on the other hand, I think we need to broaden beyond that, in reality, beyond family planning and just HIV, to many of the other services that the young women need that go beyond health. I mean, one can focus around health-related services, but as we learned from this report, there are many other dimensions of services that these young women need, and where and how to integrate those and who will do that is a very important question. There needs to be a lot more support for innovation, support for experimentation on trying to bring together services from different sectors, and where do you put those services, and who provides them, and who's responsible for them, and who pays for them. These are very complex issues, but I think this is the new frontier. If we're going to be able to address the needs of these young women, we have to think outside the box, rather than the traditional just family planning or antenatal care and HIV prevention. Those are the ones that we've really focused on, unfortunately, and we haven't gone beyond that. I do think it's also important to think of where and who, because young women and adolescents exist in different populations. They're the ones that you mentioned, Judy, the ones who are the most vulnerable. There are also others who are in school, but are still vulnerable. There are others who are in the workforce already. And what can we do for them in the workplace, for example? So I think there are many, many different places and settings and populations and subpopulations that we need to design specific services for those different populations and think about how to make that happen and how to learn from these experiments and hopefully identify the simple, scalable interventions that can then be used in many other settings.
Great, thank you. One more question for our panelists, and this will be for the government of Ethiopia, our government representative, to talk about a really critical part of this, which is how do you engage the government and the local government to really be involved from day one, but also be ready if something works to take it to scale and sustain it. And I know that's a hard question to answer, but if you can share just some of your thoughts about what do you need to see, and what kind of support do you need to make that happen from the government's perspective?
Okay, thank you very much. In fact, this question should be answered in terms of our priorities. We have specific priority areas, especially when we work in partnership with other stakeholders. As you know, power and the resource has been decentralized to the local level, from the federal to the local level. Therefore, in terms of implementing our priorities, especially which are related to gender equality and women's empowerment, there are 3 priority areas. Those are education, health, and livelihood development. Therefore, in order to make the local governments, regional, district, and local governments capable of implementing those priorities, as I mentioned earlier, one of the most critical issues is the capacity building issue. We always request our partners not to always implement by themselves, rather to build the capacity of local government authorities, local institutions, so that they can lead programs at the grassroots level. Therefore, capacity building is a key issue for the government in order to effect those priority areas, the education, health, and livelihood development activities for the benefit of the people. In addition, we also want any partner to invest on local structures other than the government structures, which I mentioned earlier. There are different structures at a grassroots level. The women development groups, the community care coalition groups, and so on. Therefore, if we invest in those structures, these are local structures created to respond to local needs, using local structures, using local resources. Thank you.
Thank you very much. So now we are ready to go. Already see lots of hands. Go to questions, and we will do the 3-question strategy since there's several hands. So please say who you are, what your question is, and we'll take 2 more, and then we'll turn to our panelists.
Jill Gay, Chief Technical Officer, What Works Association. My question is for WAFA, and it spans both the reproductive health and the HIV. We know that adolescents living with HIV, of whom there are 2.2 million globally, do not really want to go to pediatric services, and they don't want to go to adult services for many good reasons. And yet, how do we scale up adolescent-friendly services within government services so that it is sustainable? And on that note, we know that sexuality education, which is sort of key, has yet to be scaled up in any lower or middle income country.
Next question, please.
Hi, my name is Amy Lin from USAID Center for Accelerating Innovation and Impact. Thank you for describing this program, and it's impressive how many thousands of girls you have reached so far. I was wondering if you could describe more about the other types of results that you've seen, either in educational attainment or health outcomes or something else from the thousands of girls that you've reached. And then for Dr. Haile, to build on your last response, I'd be curious on how you see this program continuing in Ethiopia going forward. Do you see it as part of the government program, the health extension workers that you mentioned and the other components, or do you see external funding or other resources continuing to be required to sustain it?
And last question for this round.
I'm Ellen Weiss. I'm with the Population Reference Bureau with the Evidence Project, working on family planning and reproductive health. And my question is about the C word, and that's cost, and whether or not y'all had collected any cost data, and what your ideas are on how to use that cost data and how to be creative about cost effectiveness, cost benefit, and not just about the program, but also thinking more strategically about what's the cost of inaction. Because the two pieces of information that really struck me today, I've worked on HIV for a long time, was Danielle's about slide about how many girls get infected per week, and Judith's about the percent of girls that are going to be single mothers. So what's the cost of inaction?
Thanks. So we had a couple directed questions, but also some broader questions. So who wants to start? I think, Wafa, there was a question for you first.
I can start. I think it's a very important point about adolescent HIV-infected adolescents and what can we do for them. I agree with you completely. And the issue is, where do they belong? And there's been a lot of work that's been done on how to transition young people, adolescents, from pediatrics to adult clinics with some success, but it's been with maybe limited success, I would say, or not as successful or as streamlined as it could be. I think there have been interesting innovations that have been happening over the past several years. I think there's been a lot of work on sensitizing the workforce, particularly the adult providers in general, who are used to dealing with adults and just don't have any patience at all for adolescents, for some obvious reasons. But a lot of training of healthcare workers has been done in multiple countries to be able to take care of adolescents with HIV, as well as the establishment, for example, of mentorship. Even in the clinical setting, adolescent mentorship groups where young HIV-infected adolescents are providing support for other adolescents within that clinical setting. And lastly, I think the establishment of adolescent support groups, which have been quite successful, rather than mixing kind of the support groups are all encompassing. The idea of having adolescent-specific support groups has been quite successful because their issues are very different from some of the other issues. And then being creative in terms of even if you don't have a specific clinic, just the timing of when these sessions are and offering them a specific space within health centers. So I think that a lot has been done, and I think it needs to be disseminated and adapted and scaled up to meet the needs on the ground.
Okay, thank you. I'll respond to the question about any other impacts of these projects, including educational and health impacts. We did recently, last year, we included a study for Baru TESFA to actually measure learning outcomes as well as health impacts. And we found that particularly for Baru TESFA girls who had never been to school, they made significant improvements in their learning outcomes, both literacy and numeracy, compared to the control girls in the control arm of the study. Also, as part of Baru TESFA, we had a health voucher. And the reason that we started that health voucher is that a lot of the Baru TESFA girls were rural urban migrants. There's not a huge health infrastructure in Ethiopia, so a lot of rural populations don't really have the habit or the exposure to the health infrastructure. So you would find these essentially rural girls coming into these urban areas, and they're young, they're 12 or 13. They don't know how to maneuver. They don't know the first thing about how to go to a clinic. So we had found that a lot of the girls, when they got sick, not only had they never been to a clinic and didn't know how to go to a clinic, but they often would not even have, often at many of these clinics you have to buy a clinic card, which is about 20 birr, and they were maybe earning 50 or 60 birr in a month. So we offered a voucher system, which particularly in the private sector, to subsidize the cost of health services. Very importantly, when we offered the voucher, we also offered accompaniment to the clinic. Because remember, these are little girls, 12 and 13. They're often too scared to go to a clinic for the first time, never having been to one. And in fact, 80% of the girls who took the voucher asked for accompaniment by their mentor. And again, at N-Line in that same study, girls in the Beru test file were significantly more likely to have ever used a health service compared to the girls in the control. I would say another impact, beyond education and health, another impact which is more of perhaps a sensory impact is that, if you think about, I think that these programs had the effect of raising the visibility of the girls. Because before that, these were child domestic workers. They were locked in these homes. People had no idea sort of how many of these girls there are in the community, how many girls there were in these conditions. But when we successfully mobilized this great number of girls, and they had an identity, and they had a T-shirt, and they would all go to these centers, suddenly they had, they were highly visible in those communities, and that made a big, big difference, both in their own status and also, protection within those communities. I can talk about cost. So we have some cost data that's within the publication. I think we've said, according to some work we did previously with Judith and her team, it's about $52 per girl per year for Beru TESFA. These interventions are specifically designed with cost in mind. So we try to make maximal use of existing resources, including we used existing, for example, Kibeli community facilities, as well as we made use of local resources. These mentors are living in those communities and women leaders drawn from those communities. And so they were actually very low-cost interventions. I think that for the future work, for the next generation of work, and in some of the work we're doing in Ethiopia, we are prospectively tracking costs. I think definitely we need to do more work in all of our programs to prospectively track costs, but they are lower costs than a lot of people often imagine.
I think the last question for this round was for Dr. Haile, which was about the government. Going forward, will you be able to pick up this program? What kind of external resources, if any, would you need, if that's something you can speak to?
Thank you. Sorry. Most of the effective and efficient experiences and practices which are run by different non-state actors are currently institutionalized into formal government-based activities. However, although we are trying to incorporate to sustain some of the programmatic issues into our formal structures, formal activities, still there are areas, gaps. For instance, as I said, the health extension system should be strengthened. We have over 40,000 female health extension workers who are working at Kabali level, at the locality level, at the community level. But still, there are, especially in urban areas, we need more health extension workers because we have started in rural areas where the problem is, but urban areas still require more health extension workers. Therefore, in that area, we still require further support from our partners in terms of training, in terms of skills, and so on. Also, as I said earlier, we want to invest more on community structures. On the structures at community level, both government structures and other community-based structures. That requires a lot of money. For instance, as I said earlier, we have 450,000 Women Development Army. One Women Development Army or group consists of 25 to 30 women who are living in the neighborhood. These are voluntary organizations, voluntary groupings. They require training. they require skill development. They have their own investments, they have their own saving and so on, but still they require a capacity building kind of thing. Therefore, we have to strengthen the community-based structures, because these are instruments in bringing transformation and change in the community. Therefore, although we are trying to institutionalize the best practices into government activities and plans and programs and so on, still we have the gap in terms of financial and technical resources that should be covered with our partners. Thank you.
Thank you. Judith, you wanted to add?
I want to make a comment on the cost, and Ellen, it's a great question. So 3 general points. The first is that getting the compared to what question is really important. Every analysis we've done shows these girls get nothing. If you think of a community like this, here are all these delivery systems. They are not reaching these girls, period, full stop, right? If you build it, they will not come. So then you decide we want to reach them. And to some extent, the cost effectiveness will be both what does it cost to reach this population, and we're at the point now, happily, where we can do, I think, some pretty interesting operations research to see, all right, at what point can you vary mentoring ratios, at what point might community incentives work, et cetera. The other piece is that they're living amongst, in many cases, in the urban areas, a density of services that they have no access to. So you are basically increasing the efficiency of what's there. In many cases, things dedicated with their name on them, but they never got there. Now, some governments actually think of that as a cost, not a benefit. So, we've been through this recently in a conversation in Rwanda in which the girls are technically covered under the Social Security, but they don't for help, but they really don't want to see them. So, the check-in by 12 program will have every girl making a health visit, which they should do, because the broad cost benefit is that prevention's better than treatment, right? But that's always there's a bit of politics there. But in effect, to see vastly underutilized services, which many of the youth initiatives are, or either services that are underutilized either overall or by the group that's supposed to reach them needs to be in the picture. So I'd say compare it to, we're not reaching them now, so job one, reach them. Then from that, get the yield. What did we avert that was bad, right? And we should add some things there that we think are bad, like coerced sex and so forth. Maternal mortality's in there and some other things in HIV acquisition, but we need to have a few more benchmarks of what's good. A little, being in school at grade for age, or some of the more cognitive tests of who can read a sentence and so forth. Over the short term, and all these fit into, and then over the long term, your question about, yes, I think by excluding this bottom 40% of girls, this is Planned Parenthood. We can show it. You are laying the foundation for a much more robust workforce, investments in children, health, all the things we know, the flywheel, the positive flywheel. Lastly, those who've studied the cost of movements and collective bargaining, that's also should be brought in play, because in effect we're creating a class, and we're investing in a class, and what Annabelle's talking about, girls are visible, people have voice. That's, for people who talk about governance, this has to be factored in too. Unless you have a density, a local density, you don't get that. So I think there are returns on all those 4 levels probably.
Great, thanks. Believe it or not, we only have about 4 minutes left. So 3 very quick questions, very quick answers, and then we're going to have to wrap up. So, sorry. Over here, back there, and then on this side.
Hi, thank you. My name is Janet Fleischman with the CSIS Global Health Policy Center. I also had a chance to visit your program in Amhara and can also attest to the remarkable girls and their mentors, and having had amazing conversations with them. And I'd just like to quickly draw you out a little bit more on, even though it wasn't the main focus, the access to information and services on family planning that these girls have benefited from. And that links also to the broader health, reproductive health information that would link with the HIV services. Can you speak at all to that range of impact and as another form of protective asset? Thanks.
Good morning. My name is Gina Branham from the Office of AIDS Research at NIH. And my question, this was a great set of discussions. My question is about the lessons learned from both implementation, particularly when you've got to get kind of male buy-in or power buy-in to involve girls in these activities, but also the impact of involving these girls in these activities now that you've got sort of strengthened and, women with much more of a sense of themselves who are going back to a community that may or may not be used to women having that kind of sense of self.
Last question, I think, was over here. Yeah, the back there. I'll let the two of you decide who you want.
Arm wrestle. Yeah, okay. Beverly Nyberg from Peace Corps. The other option was also from Peace Corps. But who knows if the same question, yeah. My question is related to the one that was just asked. It's about the resistance to the program and the mention of the program for men, the New Light one. What was the effectiveness of that? And did that help address resistance to the change among the girls?
Great. So really quickly, I'm going to ask our panelists to just, and probably mostly Annabelle on some of these questions. Give everyone 1 second to say their last bit, and I'm going to close.
Okay.
All of those.
I hope so. I'll just say a quick word on the access to family planning. I think that is also an area that we should go more in that direction, particularly with the girls' groups. When we worked with Meseret Hiwat, if you read the publication, you'll see that girls who participated in Meseret Hiwat were more likely to be using family planning than non-participants. And if both she and her husband was participating, then they were even more likely to be using family planning. I think that in the Amhara region where we work with these married girls aged 15 to 19 have the highest unmet need for family planning. In our field, there's a lot of assumption that they have to prove their fertility early in the marriage or that they don't want to use family planning. That's not coming out certainly in the DHS. And I think that the direction for a lot of in Ethiopia for the married girls work should be more concentrated and directed promotion of family planning. So thank you for your comment. I'm not sure I would like Judith to talk more about, if you could, about the male buy-in. But again, just to say that when we did the Meseret Hiwat work, when the husbands participated, the impact was greater. There was a kind of an incremental improvement in the different outcomes, including assistance with domestic work, going to clinic, using family planning, wanting to have VCT, having couples VCT. So there was an incremental improvement when both, the husband and wife participate in the programs. And I don't know if Judith can say
Judith, really quickly, because we are actually 5 minutes over.
In this instance and another instance, basically we began with a female population and then we moved to a male population. And I think once you have the specific female population, then you can decide which males, whether you engage, which males are important. In Upper Egypt, it was the younger brothers. When the investments in these girls are consolidated and at what cost. And this is the cost. It is often more expensive to engage males and females. Their opportunity costs are different. That said, the best possible design is that you find those populations which you can engage at reasonable cost, so it will enforce things that are important to our first client. The aspects of the program where you had the most trade-on was where both males and females stood to benefit. When it was things like sharing domestic work and things like that, not so much, but it was, in general, you're looking for areas where both male and female well-being is served, and they see that.
Since we are out of time, Wafa and Dr. Haile, did you have anything you wanted to just say at the last word before I close? You don't have to. You can say no.
I think you're inviting me to say no. Thank you.
Dr. Haile, would you like to add anything?
Okay. Also, a specific question not directed to me, but for a final word, we are in the process of transformation. In fact, still we have a lot of gap, not only in terms of adolescent girls, but also in other areas. Therefore, still the government is striving towards ensuring equitable development, towards benefiting people, more people, all people. Therefore, in this regard, strategic partnership, multi-sectoralism, more coordinated response, harmonization and synergy is important in addressing all kinds of vulnerability in our countries. Therefore, any interested non-state actor is welcome to invest in our country because we have a lot of enablers, policy, normative, and strategic frameworks. Thank you.
Great, thank you. So before we wrap up, I just want to say a couple things that there are a lot of important messages and themes in this report and this panel. A few that jumped out, and I hope everyone just takes with them to think about. One was who and where and when is so important, and mapping that. And we didn't talk as much about the when, but the report talks about early, reaching girls early. Two, we heard about the compounding effects of vulnerabilities, but also of interventions, so that's really important. Three was the focus needs to start on girls and young women, the first client or maybe the main client. Four was measuring and addressing protective assets, and assets defined broadly to include a range of services. And then five, local investment and the buy-in locally is so critical, and related to that, the cost is not that high for some of these interventions. And so we heard, I think Judith said, don't listen to the naysayers. I think fortunately for women who have been working on this for years and allies, we don't listen to the naysayers, so we do forge ahead. So I want to, the audience here is full of experts as well, but I'd ask you to join me in thanking our panelists and the POP Council for this event. Thank you.